Thank you for joining us for today's webinar. The title of our webinar today is Early Parkinson's Disease, and we're going to be providing you with a discussion on the benefits of a speech treatment called LSVT LOUD. This webinar has been brought to you by LSVT Global, and we have listed our contact information for you at the bottom of the screen. My name is Laura Gousset. I'm a physical therapist and one of the LSVT BIG training and certification faculty. I also serve as the Chief Clinical Officer of LSVT BIG for LSVT Global. I will be moderating today's session, and I am so excited to share with you our guest panelist, Beth Peterson, who is an expert in LSVT LOUD treatment, especially with patients with early Parkinson's disease. Beth is also our LSVT LOUD training and certification faculty for LSVT Global. So we thank you for joining our webinar. If you're new to our webinars, I want to give you some basic information on the flow of the webinar and some logistics. You might notice in your control panel that there is a tab that is titled Handouts. In that handout, you can find a PDF copy of today's slides. So if you'd like to save it, download it, or print it, it is there for you in case you didn't receive it prior to the webinar. Right now, everyone's microphones are muted in the audience so that there is no background noise from the various environments from which you might be joining us. At the end of the webinar, however, we'll have a time, maybe 5 or 10 minutes, for you to ask questions related to this topic of early Parkinson's disease and LSVT LOUD. At that time, I'll explain to you a little bit more about how you can ask your question out loud once your microphone is unmuted, or at any time during the webinar, you can type in your question into the question box on the control panel. We'll stockpile those questions and answer as many as we possibly can at the end of today's webinar. The plan for the webinar is basically this. We're going to review and discuss early Parkinson's disease and LSVT LOUD as presented by Beth. We'll also discuss your questions related to this topic at the end. Before you log off, there will be an opportunity to complete a survey at the end of the webinar. It's very short, but we do really value your feedback on the webinar, so please do take time to complete that survey. Briefly, here are our biographies. Ms. Peterson received her master's degree in speech, language, and hearing sciences from the University of Colorado Boulder, and she has been working with one of our founders, Dr. Lorraine Ramig, on her research team while completing her master's thesis. Beth is now LSVT LOUD certified and has delivered LSVT LOUD extensively in a research setting. She's worked as a research associate at the National Center for Voice and Speech in Denver and at the University of Texas Health Science Center in San Antonio. And she continues to be on Dr. Ramig's research team. So very excited again to bring Beth's clinical expertise to you. We do have some basic disclosures that we always like to share. Both Beth and I are employees of LSVT Global and receive lecture honorarium from LSVT Global. Now, this webinar is intended for a public or a lay audience, including persons with Parkinson's or family members or caregivers. However, this is a webinar that's open to anyone. So if you are a healthcare professional, especially a therapist, you are certainly welcome to attend this webinar. But we do want to note that it's not ASHA or state registered or pre-approved for CEUs, but you can use it for self-reported CEU credit. So if you would like to report your activity on your own, please email us at webinars@lsvtglobal.com after this webinar to request a certificate, and we will email you a certificate which will include your name, the date, and the duration of the webinar, as well as the title of this webinar. So please do check with your state for licensing requirements and determine if your state accepts non-pre-approved CEU activities or non-ASHA registered CEU activities. If you do want a certificate to self-report, please note that you must attend for the full hour to earn that certificate. These are our basic learning outcomes for today. After completion of this webinar, we hope that you'll be able to summarize some common communication issues facing individuals with early PD. Secondly, we want to discuss how early therapy intervention helps the brain change in positive ways. We'll be discussing some research findings on LSVT LOUD in early PD. And lastly, we'll be describing practical solutions for completing LSVT LOUD. So with that, I'd just like to open up this discussion with Beth and ask the most basic of questions. What is considered to be early PD?
All right, great. Thank you so much, Laura. And I'm very happy to be here with everyone presenting on this important topic here today. So thank you to everyone for joining us. So yes, to really get us started here with a discussion on what is early PD. And so there are various definitions out there, but in general, and kind of the overall consensus is that early Parkinson's is defined as 5 years or less since diagnosis, and then also Hoehn-Yahr stage 1 to 2. And we'll see next a rating Parkinson disease severity scale that really kind of outlines what the Hoehn-Yahr scale is so that you can better understand where that stage 1 and stage 2 come from. So if you're unfamiliar with the Hoehn-Yahr rating scale, this is used by neurologists and movement disorder specialists to classify the disease severity for Parkinson's. So again, with early PD, we're looking at that stage 1 through stage 2 that's highlighted in blue here on your slide. So that stage 1 would be unilateral disease, stage 1.5 unilateral plus axial, kind of more that core involvement. Stage 2 would be bilateral disease without impairment of balance. So that's the stages that we're looking at for early Parkinson's. And again, also within 5 years of the initial diagnosis. So just to kind of give you a framework for what we're looking at with early Parkinson's in terms of the time since diagnosis and then also the disease severity. So what we will learn though throughout this presentation is that early Parkinson's may not be so early. So even though the diagnosis or it's classified within the first 5 years of diagnosis, by the time that diagnosis of Parkinson's is made, their neuropathology is already advanced. So this deterioration may actually precede clinical diagnosis by 4 to 6 years. So that means that by the time you go to the neurologist or get the referral to the neurologist for some symptoms that you're seeing or noticing, likely there have already been changes going on, and we'll have some slides to kind of give you a better picture of that, but before that clinical diagnosis was made. So Parkinson's was already there, but it has not been diagnosed yet. So that becomes really important for us as clinicians and therapists, because delaying any type of intervention or therapy may put the rehabilitative efforts at a disadvantage due to those reduced neural substrates that may be available for behavioral recovery or compensation. So we may already have lost some of that kind of that neural substrates and neural activity that was there that we now can't make up for as much as we could earlier on. And so that's why we really, and you'll hear this point a lot in the presentation here today, even if you don't notice so much overt voice and speech symptoms, just know that the disease, again, has already began and progressed by the time a patient is diagnosed. So it's so important to jump in there as early as possible before it's beginning to deteriorate even more. And it's harder to bring patients back up to that level where we know we can kind of maximize their capability and overall communication. So knowing, again, kind of thinking about that early Parkinson's, even though it's early in the course of your diagnosis, may not be so early. And this next slide kind of shows you kind of what that looks like inside. So we're looking at here pathological findings of Parkinson's. And so one of the hallmark pathologic features of Parkinson's is a massive loss of pigmented dopaminergic neurons and the part of the midbrain called the substantia nigra pars compacta. So you see that listed on your slide here as the SNPC. And so on the slide, you see some slices of the midbrain. On the left, you see some black areas on either side, and that's the substantia nigra. And on the right, you see those same areas that are depigmented. And so you can see the one on the left is an individual without Parkinson's. The one on the right is with Parkinson's. So the one on the right, again, is depigmented, so we're not seeing those black areas. And that's symptomatic of someone with Parkinson's and is the main neural basis for idiopathic Parkinson disease. And what we're seeing on the bottom of the slide, so it's showing that there's a 50 to 60% cell death at the time of diagnosis and a 70 to 80% loss of dopamine terminals, which precedes the diagnosis by 5 to 6 years. So again, there's a lot going on, again, at that neural level before the diagnosis is made. So again, why it's so important to jump in, start those intensive therapies while you have as much capacity to improve as possible, because again, it's already progressed before the diagnosis has been made. All right, and then another distinction I just wanted to point out is early Parkinson disease versus young onset Parkinson disease, because I know these sometimes are incorrectly interchanged. So young onset Parkinson disease is the diagnosis of Parkinson's before the age of 50. Approximately 10% of the 1 million people with Parkinson's in the US are thought to be below the age of 40.3. And then, so just something to keep in mind, so all individuals with Parkinson's will have a stage of early Parkinson disease, whether they're diagnosed at a young age or an old age. So when we're referring to early Parkinson's, it can be either someone that also does have young onset Parkinson's or someone that was diagnosed later. But for the webinar and purposes of the webinar, we're going to focus on that early period, kind of regardless of the age of diagnosis.
Okay, that's great, Beth. And you mentioned that the symptoms might be somewhat subtle when a person has early PD. What are some of the voice or speech symptoms that can be detected?
Yes, so let's definitely get into that next section here. So some of the early changes in the speech motor system, the first point on this slide kind of just shows you that previously kind of what we call medical chart review literature suggested a mid or late stage onset of speech and swallowing symptoms. So even the literature wasn't really documenting that some of those symptoms were occurring right away upon diagnosis. But more recent investigations with more sensitive and valid measures do consistently report speech and swallowing systems very early in the course of Parkinson's. So we'll see what some of those are. We have some of those listed on some of the slides coming up. We are seeing early speech and voice dysfunction in 78% of cases. So it can be reduced loudness, mono loudness, so monotone in pitch. So again, not much of that pitch inflection, hoarse, harsh, or breathy voice quality. So those are some of those early symptoms that we're seeing. And with this, again, because this may be more subtle, people may not realize that an individual does have Parkinson's. And so they may just see them as someone who seems bored or disinterested or apathetic because they're not as lively or engaged, because some of these symptoms are already going on with their communication. So again, another reason why we really want to jump in early and try to do as much as we can to preserve what's there and also improve it. So there's also some non-motor characteristics of early Parkinson's that are related to communication. So even people who are clinically asymptomatic for speech deficits do report feelings of embarrassment, social stigma, and isolation due to speech concerns. And so that's done, that was some of the research done by Miller and colleagues in the UK. And so does this matter? And definitely it matters. So there's consequences that include being excluded from conversations, feeling a loss of dignity, and feelings of misery for many of these individuals. And it might be because it's not so obvious what's going on, but they're feeling, differences, they're feeling changes, they're noticing, subtle changes in their conversations with others. And it can affect their confidence with communication, or maybe they worry about what's going to happen to their communication, so they're already kind of worried and starting to withdraw or become a little more isolated. So again, why we want to get in there early so we can keep up that confidence, maintain what we have, improve it, so we really have these confident communicators all as soon as we get the diagnosis. So that's where we really want to start.
Okay, so got it. But what if a person says, and I know that I have witnessed this in my own patients that have come to me in physical therapy, if they say, I really haven't noticed any changes in my voice or speech, or no one's really said anything that, I've had changes in my voice or speech, why should I do intensive therapy now? Like, why can't I wait until I'm starting noticing symptoms?
Yes, and that's a great question, and one that we get both from speech therapists and patients alike. How should I work with this person, or why should I go see a therapist if I haven't noticed any changes in my voice or speech, or my neurologist hasn't told me that I should go seek a referral? So why should I do intensive therapy? So an SLP, or a speech language pathologist, we do have a role in early Parkinson's, and that's to assess and treat speech and swallowing disorders. So we kind of look at this in three ways. First is to improve physical capacity. So we're really doing physical exercise of the speech and swallowing mechanism to improve those muscles so that they function as optimally as possible, both for speech and swallowing. Also preventing inactivity. So we want to make sure people are speaking, participating, in social situations, jobs, or community. So at church, at work, with family members. We don't want to wait until we see so much decline that, again, it's harder to bring them back up, or that they have felt like, oh, I just, I don't have as powerful of a voice at work. Some people we see are cutting back at work. Either they're noticing fatigue by the end of the day and they just can't handle, all the phone calls they have to do at work, or the presentations they have to give, or they start giving up speaking parts to other people in their company. We have a video that we show the therapists at the workshops that we teach, and it talks about a lady who gave up her speaking responsibilities to the president. So she used to make all the announcements, but now she doesn't have confidence in her voice. So we don't want that to happen. So we're thinking of it as preventative too, working where we are, so that we don't get to those levels. And then also educating. So we mentioned on the previous slides that there is some fear of what will happen in the future and losing the voice and the speaking abilities and what may happen. So let's jump in now and prevent that fear and show, well, look at the power you have now. Let's improve that power even more so that you can continue to use this louder voice, this better voice and overall communication. We'll also talk about some of the sensory or internal cueing deficits that occur with Parkinson's. There is a sensory mismatch, and this can be really with a lot of things with Parkinson's, with both movement, so thinking that you're moving big enough even though your movements are smaller. And specifically for speech, for the topic today, you may think that you're speaking loud enough, or that your spouse or other people need a hearing aid, because it feels loud enough to you, but really it's not loud enough. And so there's that sensory mismatch between what's being output and what you're producing versus what is actually being produced. So we'll talk a little bit about that, but that's also part of the SLP, or the speech language pathologist role, is to work on that sensory mismatch so that you are able to internally cue and know the amount of effort and loudness you should be using to speak within normal limits, in terms of voice and volume in everyday conversations. So another point to make here with SLPs, we train, so in LSVT LOUD, we spend some time training SLPs to unmask the deficits of early PD. Because again, our goal and kind of our dream would be, upon diagnosis, every person was referred for both physical or occupational therapy and speech therapy. So then we get those questions from clinicians who say, well, the neurologist didn't refer, or I didn't notice any changes. So one thing we always have them think about is, well, if you're in a quiet room, one-on-one across the table, or they're with the neurologist for 5 to 10 minutes, again, just a small clinical room, maybe you aren't having any trouble there. But what if there is an added cognitive or motor load? So again, tapping into, well, how are they doing at work when they have to answer the phone all day, or they have to type while they're talking on the phone? So during the assessment tasks with an SLP, they'll do some added cognitive or motor tasks to see, does the communication change? So does that quality change? Does that loudness drop when we add on either a dual motor task, so something where you're moving while you're also speaking, or we may ask you to, solve a math problem in your head while you're doing a speaking task, and does that change your communication? Because what we're trying to do is emulate what's going on in the real world, where we know you're walking and talking and moving and talking and thinking and talking. So we want to try to emulate that as much as we can in the clinical room. And so we'll try to unmask those deficits. So sometimes that added load can unmask a soft or monotonous voice that may have seemed fine, again, just in a 5-minute conversation with a neurologist one-on-one in the clinic room. And we'll also often give out communication participation scales. So there's a couple, or one listed on here, the communication participation item bank, and that's a perceptual rating scale that patients can fill out related to their overall communication. And so they can rate if there's certain situations where they feel, weaker or stronger in communication, and we're trying to, get a sense of the overall negative impact on communication participation. So we're trying to identify subtle changes that a person might not overtly identify with changes in speech and voice as well. So for example, it might not be that a person comes in and says, I've lost all volume, or I really notice, hoarse voice quality, or I don't inflect my voice as well. But it might be that we're seeing, kind of bigger picture themes, like, oh, I don't enjoy doing my volunteer work anymore. Oh, why is that? Oh, because I don't feel like people talk to me as much, or people are always leaning in with me. Or, I used to have these great conversations with my best friend from high school on the phone, but now our conversations just aren't as deep. And, why is that? Oh, well, she asked me to repeat a lot on the phone. Or we just, it just gets frustrating because, it's difficult to understand. So there's things that we can these themes to see, okay, why are you having trouble in those situations? And point it back to, oh, well, maybe it is due to communication and some changes going on. So those are some ways an SLP, specifically one that does LSVT LOUD, is trained to unmask those deficits. And why, even though, you may say, or your neurologist may say, oh, I haven't really noticed changes yet. But if you do go in for an assessment, the clinician can kind of tease out some of those differences and then use these to make very functional goals for you. So if you're having trouble, again, maybe talking on the phone while typing notes at work, then that would be a goal that you would work on in therapy. And they would add in some tasks where you are doing some typing while you're doing the voice exercises, because that's what's going to go out into the real world. And we want to make sure from the beginning of therapy to the end of therapy that you improve on that task, because it's very functional to your everyday living, your work or your job or career, so that, again, we would really personalize and tailor it to what's going on in your life. So we have some considerations to think about. So SLPs are the voice experts for Parkinson's and will be the best ones to educate you on these voice and speech symptoms, also on that the calibration issues, or that sensory mismatch, I should say, that we talked about before. They'll help establish a baseline. So where you're coming in, what's your vocal loudness, what are, some of the voice characteristics, communication issues going on, and again, help design a customized treatment plan for you. So general voice exercise, so people will say, oh, well, I'm part of a choir, or I'm, singing at my church, so I'm getting practice once a week. Can that work? So general vocal exercise does not include functional task-specific training that's important for your life now and later. So singing, well, if you enjoy it, that's certainly we want you to keep doing, and we think that's fabulous, but we would want to work with you, again, on a very tailored plan that's very functional and specific for you and the goals that we would want you to achieve based on the issues that you're having and based on what you want to be doing outside. So SLPs also understand the underlying pathology to assure that vocal exercise is safe and comprehensively address your Parkinson's. And general vocal exercise does not address that sensory deficit that we talked about, where there is that sensory mismatch, where individuals with Parkinson's do feel like they're speaking loud enough when actually they're speaking at a lower volume. And so we would address that sensory mismatch so that you know how much effort is needed to use a voice that's within normal limits. So in the beginning, it may feel loud to you, but we would do a lot of kind of playback and reassurance so that you could hear that voice like on a recorder and hear that it does sound great, even though it feels too loud, but it's just loud enough. And that's the amount of effort you would need to use. So those are some considerations when thinking about, should I get into intensive voice therapy right or shortly upon diagnosis? And then the next slide kind of shows, kind of a nice flow chart of what we would want to happen. So upon diagnosis, we of course want you to be optimally medicated so that you can optimize your function for everyday living and everyday situations. We also want therapy to optimize function. And again, specifically this webinar is about LSVT LOUD, but also therapy, intensive therapy that Laura specializes in, either physical or occupational therapy, LSVT big, to optimize body function and body movement. So we kind of want the big picture, both, we want to exercise for this, the voice and the speech, and PTs and OTs would help you optimize function for your body movements. After you would complete an intensive therapy protocol, then you would do daily exercise at home or in your community. So you would have home practice that you would do every day by yourself. And then also in the community, we have some groups, Loud for Life and Big for Life groups that are kind of post-treatment maintenance groups that usually meet about once a week, and it's a chance for everyone who's gone through the program to come together, work on those exercises with a group leader, but then also other individuals who are also going through the same types of changes and therapy as you. Then we have therapy tune-ups. So this would be similar to, you see your neurologist every 6 months to a year, you see your dentist every 6 months to a year. Then your therapist, you should also be adding to that rotation. So we should be part of your medical team to, again, continue to optimize the function that you have and maintain the gains you make in treatment. So we have those tune-ups to make sure that you're still in touch and kind of going the right direction and continuing to improve there. And then we say repeat. So again, going in every 6 months or touching base with your therapist every 6 months to see if you need to do any additional therapy.
Okay, that's great, Beth. And I guess I think a question that a lot of people might be wondering that aren't familiar with LSVT LOUD, you've mentioned it in terms of what differentiates an LSVT LOUD evaluation session and what their overall model of care is in that last slide, but what should they expect in the actual treatment session?
Yes, so that's a great question that I'd love to get into here. So first, just kind of the big picture, LSVT stands for the Lee Silverman Voice Treatment, and it was named after a woman who had Parkinson's, and Dr. Ramig, one of the founders of LSVT Global, worked and has done 25 plus years of research on developing the protocol that is now known as Lee Silverman Voice Treatment, or LSVT LOUD. So we'll break it up here on the next few slides so you can kind of understand the components of LSVT LOUD and what this looks like. So the first thing with LSVT LOUD, and you may have guessed that, is that the focus is on vocal loudness. And so vocal loudness is what we call the target of treatment. So we're targeting the vocal loudness, we're targeting the voice. But with that, even though we're targeting vocal loudness, we're seeing that loud is more than a laryngeal event. We're seeing a spread of effects. So we're at home or at work or wherever you are, I want you just in your normal voice to say, "Hello, Beth." And so what likely is occurring is what we're seeing on the left side of the slide. And so this would be a softer voice. So we're seeing kind of small breath support. We're seeing kind of small mouth opening. But what I want to see, and so I want to hear you say, or I guess I don't hear you, but just in your own environment, say, "Hello, Beth," in a loud voice. All right, and so we'll see what appears next on the slide here as an example of what's happening with that louder voice. So again, just with that one target to be loud, we're seeing, more breath support. So we're seeing the respiratory tract open more. We're seeing the vocal folds close more. We're seeing more neural activation. We're seeing the mouth open more, the tongue, the lips, and the jaw moving more, and out comes louder speech. But all those changes occurred with just that cue to be loud or just thinking loud. So that target is why we're saying it's a spread of effects. And again, we're training healthy vocal loudness. So we're not training individuals to go out and speak in an overly loud or screaming or yelling type voice, but it takes that amount of kind of effort and focus to bring that voice up to within normal limits loudness. So just kind of have this picture in mind of what can happen to, I guess, kind of to the body as we're doing just focusing on loud. So the next part of treatment is the mode of delivery. So the mode of delivery is intensive and high effort. So it's intensive in that it's delivered 4 consecutive days a week for 4 weeks. And each of those sessions is an individual, so one-to-one with an LSVT LOUD speech language pathologist. So they're 1-hour sessions, and there's multiple repetitions of all of the exercises in a session. So you have those 16 total sessions of treatment spread across the 4 weeks. And then you would also receive daily homework practice, and that's all 30 days of the month. So even on days when you don't see your SLP, you would still be getting daily homework practice. And then also daily carryover exercises. And those are exercises where we kind of write down an exercise for you to take your loud voice out into an everyday situation, so that you can see what it's like to use that new loud voice outside of treatment and how others respond to it. So we call those the daily carryover exercises. Those are also all 30 days of the month. And what we're really doing during treatment is getting patients in a lifelong habit of practice. So Parkinson's is going to be forever, and we want to be a part of that journey, and we want to get in and help you be able to use your voice as optimally as possible and communicate as confidently as possible. So that means now you have to have a lifelong habit of practice to use your loud voice. So after treatment, you would still be doing homework practice once a day forever, because we want to maintain the gains that you made in treatment. And this is consistent with principles that drive activity-dependent neuroplasticity. And we'll talk about that a little later on in the presentation, but basically, it's consistent with what we consider or call brain change. So that's what neuroplasticity means. So the next slide kind of shows you what that intensity looks like within a treatment session. So we have what are called daily exercises, and we have 3 of those. The first one are the maximum duration of sustained vowel phonation, or long ahs. And so that would sound something like ah, and you would do that as long as you can for 15 or more repetitions, depending on how long you're holding an ah. Next is the maximum fundamental frequency range, and those are high and low ahs. So a high would sound something like this, ah, so going high in pitch, and a low would sound something like this, ah, and again 15 reps of each of those. And then we have maximum functional speech loudness, or functional phrases. And so those are going to be 10 phrases that a patient with Parkinson's comes up with that they say every single day. And we would overly kind of learn those and practice those in treatment as well as homework practice. You would do 5 repetitions of those 10 phrases every day. And again, well, all these exercises you would do for homework as well. So that's the first half of a treatment session. That takes up about the first 30 minutes. The second half of the treatment session is what we call the hierarchy exercises. And this will progress in length of utterance and difficulty across the 4 weeks of treatment. But this is really a time for structured reading practice. So in week 1, you would be practicing your loud voice at a word or short phrase level. Week 2, practicing the loud voice at a sentence level. Week 3, a paragraph or more continuous reading level. And week 4, continuous conversation, because the end goal is to get that new loud voice into everyday conversation. And so we're building up that complexity across the 4 weeks of treatment to work towards those long-term communication goals, like the example that I gave earlier, you know, typing while answering the phone at work. And so things like maintaining the number of hours that you work at your job, things like that would be some of your long-term functional communication goals. At the end of the session, we also would hand out or assign homework, and then the carryover exercise. So this is what a treatment session would look like, and you would be doing this 4 times a week for 4 weeks. And the next slide kind of shows an example of, even though, you know, some of those exercises like the long ah, you may think, well, am I going to be doing an ah at my job? But the long ah is kind of your warm-up, or it's building that strength for your vocal folds to improve. Just like you go to the gym and you lift weights to improve your muscles in your body, we're improving those muscles and that vocal function in your larynx or your voice box. But the end treatment goal is to have a louder voice in conversation. But it takes kind of those building blocks, how we kind of like to call them, to work up to that end treatment goal. And the third kind of element of LSVT Loud is calibration, and this addresses the barriers to generalization. And so this is a really key component of the treatment that's going to address that sensory mismatch that I talked about earlier. where you may feel like you're talking loud enough, but others can't hear you and are asking you to repeat, even though it feels loud enough for you. So the quote that we want to hear from every patient that we work with is, if you don't feel like you are talking too loud, you are not talking loud enough. And so by the end of treatment, you should know how much effort and how it should feel to get to that voice. Again, it's just healthy vocal loudness, but it may feel loud to you. And a lot of times that loudness gets easier to achieve as treatment progresses, because we progress in that very hierarchical speech structure. But you should feel some effort, and you should know how much effort to use to get to that normal loudness level. So we're working with calibration to really retrain that sensory perception of the amount of effort and loudness needed to speak with a normal loudness level. So, because what we don't want to happen is you come in and have these great sessions with your therapist, you get this nice loud voice with him or her in the treatment room, but then you leave and you don't carry over this loud voice into work because you don't know how much effort to use, or it feels funny to you. So with calibration, we're getting you more comfortable with the louder voice. We're educating you more on the importance of it, so that you can and will use this loud voice outside of treatment all the time.
Okay, that's awesome, Beth. And I'm just thinking again with my patients, I think that it's really, really exciting with my patients who are newly diagnosed and have early Parkinson's disease, the potential to, really slow the symptom progression, make positive changes in the brain through LSVT big. And can you talk to us about that topic, also related to LSVT LOUD's intervention for people with early PD?
Yes, definitely. So I think, the big question, how can LSVT LOUD be applied in early Parkinson's? So I mentioned earlier about neuroplasticity and kind of just gave a brief introduction about how that really is brain change. So LSVT LOUD is consistent with principles that do drive neuroplasticity, and we'll talk about what some of those key ingredients are, but just knowing that the exercises you're doing and the intensity and effort level are consistent with, again, those principles and ideas of making brain changes, and they're administered in an intensive manner in order to challenge the impaired system so that you can still make brain changes even at an older age. So we may think of neuroplasticity, in young kids. We always hear about, birth to 3, that's when their brain can make all these changes. We need to give them all the information so they can kind of soak it up. But we can still make those changes and make changes in the brain even at these older ages. And so especially, again, with early on in the diagnosis, if we can get in there sooner, that's what we really want to do. So again, let's just kind of break down what neuroplasticity is. So again, it's brain change, so making changes in the brain. And in this initial phase of neurodegeneration, the most neurons are rapidly lost. So again, that's why we want to jump in there before we lose more and more of those neurons. So that's the time where treatment can have the most impact on preventing further degeneration and the symptoms. So just as Laura was mentioning with PT and OT, the same can be applied with voice and speech and overall communication. So if exercise plays a powerful enough or mitigating palliative role, it should be performed very early and aggressively. So again, that intensity, and ideally prophylactic years before the onset of this process. So again, jumping in as early as we can before we're seeing more and more of those neurons lost, and aggressively. So when we think of that, we think of, that intensity, getting in there early, doing as much as we can early on, again, before it's harder to bring people back up to levels where they were before. And the next slide shows kind of a diagram that will show up, kind of bit by bit on your screen. But this is showing you neuroplasticity across disease severity. And so what we're seeing on the kind of the vertical axis here is the percent of remaining dopamine neurons, and then the horizontal axis we're seeing over time. And so we all lose dopamines as we age, but this rate of progression is much greater in Parkinson's. Because we know that our greatest chances for driving neuroplastic changes are earlier rather than later. So our goal as clinicians should be to try to deliver treatment for people with Parkinson's as soon as possible after diagnosis. And so not only are we educating, kind of the public or individuals with Parkinson's on this, but we educate our clinicians on this. We work to educate neurologists, on, again, making these referrals earlier on. because traditionally our referrals have come very late in the disease process. Again, when it becomes very obvious that, oh, I had to, cut back my hours or quit my job because I just couldn't speak anymore. We don't want that to happen. So we want to get in there earlier, ideally at that neuroprotection level, or again, maybe neurorestoration, before we have to go in at a more compensatory level. And that's, again, traditionally when we were referred, or patients were referred for therapy. So through that education of our communities and referring providers, we can work to achieve this goal. And then also we just kind of like to promote wellness and the importance of regular exercise in general for all people, as we know that exercise can be neuroprotective as a whole. So just something to think about, in terms of how many dopamines have been lost and how many changes have already been made by the time we get that referral. Well, that's why we want to jump in as early as possible. So I mentioned before that LSVT LOUD is consistent with principles of neuroplasticity. So here are some of those key principles, or key ingredients, I should say, to neuroplasticity that are included in LSVT LOUD. So the first one is specificity. So exercise should target the specific symptoms of Parkinson's and work on specific functional goals. So with Parkinson's and speech, so we know there's what we call hypokinesia, or basically a loss of loudness, and kind of just what we call smaller amplitude. So overall, the whole system, and you may have noticed in that picture where you got a louder voice, how the mouth was more closed. And so we really just want to increase amplitude and really specifically target what we know to be hypokinesia, that smaller or softer voice. That's what we're targeting, and we're very specifically targeting it because we know that's a symptom of Parkinson's. So that intensity we've talked a lot about. So you must work hard to achieve results. That's why we have that amount of frequency. You work hard every session, so your therapist would work you to high effort levels, multiple repetitions, always working towards accuracy. And then complexity. So a lot of times, and we just talked to our therapists about this, with individuals with early Parkinson's, because some of them, again, may have more subtle changes, we can get in there and add more complex tasks to our treatment sessions. So again, we might add in, you have to reach and pull a book off the shelf while you're doing your exercises because you're going to go to the library and be talking and pulling a book off the shelf, or pulling food out of a cabinet, or again, typing or writing or whatever it is while you're talking. We're going to add in this complexity, and that's very consistent with principles that drive neuroplasticity. So salience. So we want to make sure you're practicing rewarding tasks. So things that you feel success with, they're emotionally salient to you, to activate that basal ganglia circuitry, help you be motivated, be engaged. So for example, if you don't like football, we're not going to have you read topics about football. If you love football, then we would be pulling all the topics we can about football. We want to make sure it's very salient to you, again, just as we know salience drives neuroplastic change. So use it or lose it, and use it and improve it are kind of the flip side of each other. So what we don't want to happen is use it or lose it. So that failure to drive specific brain function can lead to functional degradation. So basically, if you're not using your voice as much, and we kind of can see this in a cycle, you don't use your voice as much because you don't have confidence to communicate, so then you withdraw a little bit more from your activities, and then that cycle kind of continues. So now you have a softer voice, and you continue to not use it as much, and you continue to withdraw more. So let's use it or lose it. What we want to happen is use it and improvement. So we're training the deficit, or training that drives specific brain function can lead to an enhancement of that function. So if you're working on your loud voice and you become more confident in communicating, you're going to use your loud voice more, and then that cycle improves, and now you have a louder voice, you're a confident communicator, so you're going to continue to use your loud voice, and again continue to drive that specific brain function and lead to enhancement of that function. So now we have this positive cycle of change, so that use it and improvement. And then we know that timing matters. The research shows us that timing matters, so that, again, the sooner you start, the better results, because we don't have to work at a level that's so low that we're just trying to bring you up as much as we can. We're working at a much higher level, and that's why we can do things like add in complexity and make it even more challenging to get the best kind of optimal results for you, so that you can continue to do the things that you enjoy and continue to work, and also can improve your voice even more, and now don't have that fear of what's to come in the future, because now you have the tools to continue to maintain the communication skills that you have. And so some things we're seeing that's really neat to see as treatment progresses. So what kinds of things are our patients telling us? So we hear things like, I hadn't realized how much I was repeating myself until I didn't have to do it anymore. And that's when we'll hear a lot, oh, you know, I guess I was always being asked to repeat or was asked what a lot. But I didn't know that until my conversations were more fluid because they were hearing me and answering my questions correctly. Or I have so much more confidence with my communication. My voice doesn't feel wiped out at the end of the day anymore. And so we talk to our therapists about that too. You know, what happens when you see a patient in the morning versus the afternoon? Do you notice a difference in their voice then? Because we'll see that a lot with early Parkinson's too. Maybe you start out fresh and everything, you know, sounds fine and works fine, but by the end of the day, you don't want to go to dinner with your friends, or you don't even want to, you know, talk at dinner with your spouse or your kids because your voice is so wiped out. Or I love how people interact with me now. So it might not be that people are going to say, oh, what a, you know, beautiful, loud, clear voice you have, but it might be that they're not leaning in as much, or they're not asking you to repeat, or you just feel more included in the conversation. So those are some of the comments that we're getting from patients as they progress through treatment.
Beth, I think that's great. And I think that many of our audience probably understands that there's a huge body of literature supporting LSVT overall in people with Parkinson's. But what can we briefly talk about regarding just early Parkinson's disease?
Yes, that's great. So I'll just have a slide up here that shows you just kind of overall. I talked about that spread of effects that you get from just focusing on vocal loudness. I won't go in depth here, but this is kind of an overall picture of the research that's been conducted on LSVT loud through the randomized controlled trials and other studies that have been done. And it's showing the spread of effects. So not only are we getting that improved vocal loudness, but we're seeing, you know, improvements in facial expression, articulation, you know, perceptual. So listeners are understanding individuals better. Vocal fold adduction, so the closure of the vocal fold, swallowing. So PET imaging would be the looking at the brain changes, or what's being activated pre and post treatment. So we're seeing, again, just through focusing on vocal loudness, this nice spread of effects into other areas of communication as well. So again, this is kind of the big picture of what the research shows, and then I'll break it down in terms of what we've seen with early Parkinson's. So from one of the randomized controlled trials, we pulled out a subset of participants that did have early Parkinson's. And so what you're seeing on this slide, on the vertical axis, you have decibels of sound pressure level. So that's the acoustic correlate of loudness, and at a distance of 30 centimeters. And then on the horizontal axis, we see pre, post, and follow-up. So pre would be right before starting treatment, post would be right after 4 weeks of treatment, and follow-up is 6 months after. And so the blue line, we see a group of individuals with Parkinson's that were treated with LSVT loud, and the orange line, you see a group of people with Parkinson's that did not receive any treatment. And so we're seeing pre to post significant change in the decibels of sound pressure level, and then also maintaining that out to follow-up. And then what you can see is compared to that group that was not treated, didn't really make significant improvements to post or at follow-up. So we're seeing, and so I should also mention the task. So this was a task, a monologue, so a conversational monologue. Participants were given a prompt to just, you know, speak about a certain topic for a certain amount of time. So this was a conversational monologue, and this was showing, again, the changes in vocal loudness pre to post and out to 6-month follow-up. So we are seeing changes that do last over time. So we'll now look at some of the new research, and this was just newly published, the most recent randomized controlled trial. And with this study, there were 84 subjects, and there were 4 groups. So 3 of the groups were Parkinson's. So there was one group that received LSVT loud, one group that received an articulation treatment, one group that was untreated, and then there was a group of patients that did not have Parkinson's. So they were used as controls or comparisons. So we'll look at the next slide that has, again, we broke out a subset of participants with early Parkinson's. The left square here on your slide is showing you the percent change in dB-SPL, or again, that vocal loudness during a conversational task. And it's looking at the solid line is the LSVT group. versus the untreated group. And so also with this most recent study, we're seeing, similar changes to what we saw in the previous study with that group that was treated, making significant improvements in vocal loudness compared to that group that did not receive treatment. This subset that was just broken out so far has just been looked at pre to post, so there's no 6-month data on these slides. So it's not to say they didn't improve out to 6 months, it's just what we looked at specifically so far is just pre to post. The right-hand side, or that right square, is, you see it's the SETI-M, and that's a communication effectiveness rating scale. So where participants rated themselves in terms of overall communicative effectiveness, and we're seeing that percent change in their scores from pre-treatment to post-treatment. Again, the solid line is LSVT, and the dotted line is an untreated group. And so we're seeing those significant changes in their own kind of self-perception of their communicative effectiveness, which we don't see in the group that was untreated, that didn't receive any treatment. So that kind of just is a brief summary of some of the research we've looked at for early Parkinson's, and are seeing changes not only in vocal loudness, but again, also the perception by the individual who received the treatment.
I think that's really interesting, Beth. And what about those people that really want to do LSVT loud? They're convinced it'll be helpful for them, beneficial, but it's just hard to, fit in 16 sessions with their busy schedule.
Yes, yep. And this is a question that we get a lot, particularly from people that do have early Parkinson's. We might have people that are still working full time, or trying to, fit in that work-life balance if they're still raising kids. So they work all day, they come home, they just want to be with their family, so they don't have time for another hour of treatment here. And they may still be active members in the community, so participating in social groups or church or support groups or whatever it is. So how can we help these individuals make time for therapy? So one idea is to utilize technology. And so I'll just briefly kind of cover what these two images show you. One is LSVT LOUD, and that's on the left, and that's telemedicine or telepractice delivery of LSVT LOUD. And there have been some research studies to show that treatment delivered over the internet, or again, kind of this telepractice, can be just as effective as treatment delivered face-to-face. And so that's one consideration. Maybe you don't have time to, go in before or after work, or during your lunch hour, to drive across town and get treatment. But maybe you can close your door to your office at lunch, and beam in with your clinician and get that hour in during your work day. So maybe that's a possibility. Or maybe some of the sessions are done online with LSVT LOUD, and some are done in person. So you can certainly talk to therapists about that possibility. And we do certify therapists in this treatment delivery, mainly just the logistics of how they do it in terms of collecting data and how they get you homework and reading exercises and things like that. But that's definitely a consideration. Another option is the LSVT Companion, and this is a software system that was developed so it actually allows you to be able to do some of your treatment sessions at home on your own. So there was a research study that was done where some of the sessions were done in person, and then some of the sessions were done with the individual practicing the exercises at home on the Companion. And so it's just a program that's installed on the computer, and it gives you very specific feedback based on the goals your therapist sets for you. So if you're not loud enough, the program will say, okay, do it again, but do it louder. And so some of the sessions, again, were done in person. I want to say 9 were in person with the therapist and 7 were done at home. But it's another idea that you could talk to your clinician about. That way it would save you time to going into the office. You could do it on your own. You could fit it better into your schedule whenever you could do that hour of treatment. And this is the outcome data that shows. So again, we're looking at purple is pre-treatment, the kind of peach color in the middle is post, and yellow is 6 months of follow-up. And we're seeing some great improvements that are made from pre to post and maintaining out to 6 months that are consistent with those reported in face-to-face or in-person treatment studies. So those are a couple of technology options that may be utilized to help make treatment more accessible. And then I'll also just cover some basic solutions. We talked about treatment during the lunch hour, so either beaming in with your clinician, or if you can, if you have a clinician that is close by, or maybe they can come into your office, so certainly talking to clinicians about that. but that might be a way to fit it in, still within your working day, so you still have your evenings or mornings with your family. Utilizing technology that I mentioned, so combining that tech and in person so that you're still fulfilling that intensity requirement, because we still need to make sure we get those 16 sessions in as part of that neuroplasticity that we talked about. And then, we talked a little bit about a post-treatment maintenance group such as Loud for Life. You can ask that later if you can beam into those via telepractice as well, so you're still getting that, kind of group encouragement, group maintenance session. And then one thing we always tell therapists also is to educate patients to think of therapy as an investment. So this 16 hours of time really in the long run is not that much time, and it can help clients, at their peak function or stay at their peak function longer, so that you can do the things that you need or want to do now. So if you can just plan out for, okay, just for this 1 month, I'm going to dedicate it to working hard with LSVT, seeing my clinician all 16 sessions, and then it will pay off dividends in the long run just to get, kind of fit it in for that 1 month. It may even help you continue to work longer. So again, that 16 hours of your life given to that treatment is worth it. And then after treatment, you would continue with your daily practice and follow-up, again, just like you regularly see your doctor or your dentist. So sometimes it's just a matter of educating patients that it's worth it and you should do it, and it's not that much time if you think about kind of the big picture of how long you'll be living with Parkinson's, and that it's worth it to do it up front so that you can maintain, your lifestyle and your work and your social situations as best as you can. So those are just some ideas to think about as you're thinking through, can I attend therapy, and what are some things that might get in the way? So with early Parkinson's especially, we say this across the board with LSVT Loud, but really with early Parkinson's, because we know that we can push patients to really high effort levels, really challenge them. So treatment should never be easy or boring, and the clinicians know this, and they work hard to make sure that it's not. They're always challenging you, they're always keeping you engaged, so your clinicians are making sure that you're always loud. Your therapist is really working to be creative with their materials to really maximally challenge you in order to drive that neuroplasticity. So that's what you should feel when you're in your LSVT Loud sessions.
Okay, thanks, Beth. Wow, that was an incredible amount of information that was really, really valuable, and I thank you for that. So just in summary, I think you did a great job showing that how in early Parkinson's disease, the pathology that underlies it really is not early. And to seek out an LSVT Loud SLP early. So don't wait until the symptoms are problematic or more noticeable, but to begin as soon as possible after diagnosis. Your LSVT Loud session should be fun, challenging, meaningful, and functional. Important to practice every day, and there's lots of opportunities and resources to support you in that. And seeing your SLP lifelong is just like seeing your dentist, and they really strive to be your partners in Parkinson's for the long term. So if you are a person with Parkinson's or know someone and you want to get started, it's very easy. Just ask your doctor for a referral and prescription for speech therapy evaluation and treatment. And you can visit our website to find an LSVT Loud clinician in your area and have the physician send the referral to that specific clinician. And then they'll evaluate you and determine if you would be a good candidate for this treatment approach. There are videos that you can rent or purchase that can help you to support you in your home practice, both during and after treatment, and those can be found on our website. In addition to some additional tools and resources, we just have a brand new website that we launched this summer that has a ton of information related to some of the things that Beth talked about, like Loud for Life, the companion, eLoud, our videos, and also LSVT Big Physical and Occupational Therapy, which has the same treatment philosophy of earlier is better when it comes to management of Parkinson's lifelong. So as a reminder for you, and we will take some questions for those of you that can stay and hang on for a few more minutes, but our next public webinar is on Wednesday, December 12th. We won't be having a November webinar due to the Thanksgiving holiday in the United States. Our next webinar is on research and clinical advances in LSVT Loud and LSVT Big. This is open to the public. And if you are an LSVT certified clinician joining us today, we'll have a parallel webinar that's more advanced and more in-depth that will be available to you. And you can register for that one. It's on a different date in December. You can register for it through your clinician account. And also, if you're looking for a more in-depth webinar on this topic of early Parkinson's disease, we just did a webinar last night, and you'll be able to find that shortly on demand through your clinician account as well. So with that, for those of you that can stay, we're going to have a few minutes of question and answer time. As a reminder, to ask questions, you can type in on the question box on your control panel, and we'll read your question out loud. It's completely anonymous, and Beth or I will answer it. The second way is that you can raise your hand. You might see a little hand icon on your control panel. Once you click on that, we'll find you. We'll call out your name so you know that it's your turn. Make sure that your microphone is unmuted, and we'll make sure your microphone on our side is unmuted as well. After that, you'll be able to ask your question out loud, and we'll provide an answer to you. If you run out of time or think of a question later, please email us anytime at info@lsvtglobal.com, and we will direct your question to one of our LSVT Loud or LSVT Big experts. So with that, I think we do have a couple of questions. One is a question that came in right now, and the listener wants to know, Beth, what's the cost for the home companion, and is it covered by Medicare?
Yeah, so that's a great question. So the cost for the home companion is $299, so $299. And so with insurance, we don't have basically, a specific protocol or specific answer, yes or no. We have had some patients that will email us or clinicians that email us and ask us what's the process. So basically, I would recommend what clients do or a clinician would do is get in touch with the insurance company and describe the LSVT companion to them. And we actually have a template that I can provide, a template letter that kind of gives some good wording to use, but just basically saying, that it's an FDA cleared medical device that and there's research behind it to show that some of the treatment sessions can be completed and some homework can also be completed on it. And then it depends on the insurance company. So we have had some success. Some insurance companies, some of the private ones actually, I think it's Cigna who actually has it written into their, speech therapy kind of regulations. It's specifically worded in there as something that is considered reimbursable. Some companies reimburse partially. So I've heard of some people, so the process was they would purchase it and then they would get reimbursed. It was either 80 to 85% of it. So specific for Medicare, I think it's kind of been a case-by-case basis, where I would recommend calling a Medicare representative, again, describing what the LSVT companion is, and I'll make a note to myself to email the participants here that, kind of the template letter that we've used before that can help. It shows the research behind it, the rationale behind it, the cost for it, the purpose for it, everything like that. And then talking to them, and then because some companies may have a specific protocol like a claim form to fill out, or do you buy it first and then submit something and get reimbursed? So I'm sorry, every time this question comes up, I wish I had a more clear answer, but I think that's kind of how the insurance scene is, unfortunately, it kind of depends. But we're happy to help you with that. So also feel free to email or call, and we can walk you through some things that have worked for other people or walk you through your specific situation based on, the response that you get from your Medicare or insurance representative to kind of help you with next steps. Okay, this is what they said. What can I do next? So, so that would be my recommendation.
Okay, and just a point of clarification, Beth, if there's someone out there that hasn't received LSVT Loud treatment yet, but is interested in the companion for the home practice, do they have to receive treatment first?
So they don't have to have received treatment, but they do have to be under the care of an LSVT Loud provider. So you wouldn't be able to purchase the companion until you have been assessed by a speech clinician. And then some people will purchase that home edition, again, like we mentioned in the presentation, to do some of the sessions independently at home, so some of the actual treatment sessions. Other
Mhm.
people may use it as a homework tool, so they'll practice at home on their own on the companion. But it is, considered a prescription type device, so you do have to be under the care of an LSVT LOUD certified clinician in order to purchase it, but you don't have had to complete treatment, because again, it can also be used for some of your treatment sessions. So you just have to be have been assessed and under the care of an LSVT LOUD provider.
Okay, that makes sense. Thank you. There's one other question that came in as an email ahead of the webinar, and I hope our listener is on here. She writes, how does therapy alter body function to improve volume? So in other words, what does therapy physically do to the body to help speech?
Yeah, so that's a great question. So this webinar didn't so much touch on it or have any images, but I'll do my best to describe it. So with voice and speech, what we're doing is we're working the muscles of the larynx or the voice box or the vocal folds. And so a lot of times with Parkinson's, what we're seeing is what we call a gap in those vocal folds or glottal incompetence. And so the vocal folds should come together and come to the middle, kind of, we call it a mucosal wave, and so if you think of two waves, kind of coming together in a healthy manner, so not crashing into each other, not overlapping, but fully closing at the middle. So we're working to basically improve that function. So we're working to improve healthy vocal fold function is the way that we think of it. And so, when we do that, we can improve things like vocal quality. We can do things like improve volume, because if there is a gap, if you're speaking and you have that gap there, then when you're speaking, you're actually losing air as you're speaking. And that can be part of the reason why you are feeling tired at the end of the day, or your voice feels tired. So we are working to strengthen your voice box, or your larynx is a muscle. So we're working to strengthen that muscle to optimize voice and speech production, because now you're exercising and speaking in a healthy manner. Doing the exercises with your clinician, and then your clinician is going to get you, they're trained to know how to help you exercise in a healthy way so that you can continue to do those at home on your own as well. So yes, we are making changes. We're strengthening the muscles of the vocal folds.
Great, thank you. So it sounds like we're strengthening the muscles and improving brain function all at the same time, which is great. Okay, and the last question that came in, and I think we'll be out of time for today, is are the changes long-lasting after LSVT LOUD?
Yeah, so the research data, and I know here we didn't do too much data, but the research studies that have been done show changes that last out to 2 years. So it's not to say that we won't continue to see changes past 2 years, because if people are continuing to practice every single day and staying in touch with their therapist, then they can continue to just maintain where they are, or possibly even get better. It's just that after 2 years, the research funding ended, so we weren't able to study participants beyond that 2 years. But what the research does show is out to that 2-year mark. So you had your treatment for a month, and we see those great improvements right at post-treatment. On this slideshow, I showed you out to 6 months, but we do have data showing all the way out to 2 years that those changes have been maintained out to that 2-year mark. So when you work with a therapist, we recommend a therapist that they check in with patients at a 6-month mark. And a lot of times that might just be a quick phone call and say, oh, you sound great. Sounds like you're continuing to do practice, go on your merry way. But other times it might be that they do want you to come in for a tune-up session or two, which is basically kind of, just a few sessions to get you back into the groove of therapy, back into the groove of homework, get you recalibrated so you know how much effort to use. So we recommend checking in at that 6-month mark, especially for those with early Parkinson's. We don't typically recommend needing to check in earlier. But a lot of times you won't need to come back for any extra therapy if you're continuing to, keep up with your home practice.
Okay, great. And Beth, if you don't mind, there's 2 last questions that I just noticed here. One of them I can answer, actually. What is the URL of the new website? Thanks for asking, Ken. It's www.lsvtglobal.com. Okay, and last question that'll truly wrap it up for this webinar. How effective is LSVT in patients with Parkinson's plus?
Yeah, so, we recently did a webinar on Parkinson's plus or atypical Parkinson's. So you may want to check that out for more specifics. But if you go to that website Laura just told you and you click on blog, then it takes you to on-demand webinars, and you have access to our on-demand library of webinars of all the recorded topics that we've done. And that will specifically dive more into atypical Parkinson's and more advanced Parkinson's. And so there is research to show that it can improve communication for that population. So that research, we don't have as much the wealth of data that we have for idiopathic Parkinson's, but we do certainly have some data to show improvements. And then we also, we encourage clinicians to work with individuals that do have Parkinson plus. So some things that, may be considered, and then we talk to clinicians about this. So sometimes the end goal for individuals that are, more advanced or have atypical Parkinson's, it might not be that they can get to the level of spontaneous conversation using a loud voice all the time. So it might be that maybe they get to a sentence level using that loud voice, or they still may need some external cueing from people, a caregiver or something. So a clinician would train the caregiver on what would be appropriate cueing in a home environment or work environment or wherever they are. There might be things, I mentioned to you about the functional phrases, and those are 10 phrases that an individual says every single day that we practice over and over again in treatment. It might be that a patient that's more advanced really kind of gets those phrases nailed so that there's a very functional impact. They've overlearned these phrases, and those are phrases that can be heard easily and understood easily by those in their environment, and that's the most important thing to them. So with that more advanced or atypical, we've certainly seen some great results. There's some research to show results, and so we do encourage clinicians, to take those referrals, seek out those referrals, but sometimes the end goal isn't quite as much as we would see with some of these patients that are earlier on or without so much advanced symptoms.
Okay, well, that's great. I just want to thank everyone for joining us today. I hope that you've enjoyed this webinar as much as I have. And thank you, Beth, for providing and sharing your expertise and clinical experience as well. This was a great overview. This will be available on demand and again, available in our blog under webinars in a couple of days. And so if you want to revisit this or share this with others, you'll find this webinar and others there. Please remember to fill out the survey at the end of the webinar, and we'll see you hopefully again in December. Have a great day.
Thank you. Thank you, Laura. Thank you, everybody.